You ready?
Hi folks, I'm going to get started. I'm hoping a couple more people may be able to join us, and we're being taped today, so I'm going to be on my best behavior. For those of you who don't know me, I'm Penny Eisenberg. I'm an occupational therapist by training and background, and I'm privileged to be the rehab director with Health Pro Heritage here, and I get the opportunity once a month to come and speak with folks about varied topics. We've done laughter, we've done dehydration, we've done strokes, and today we're talking about arthritis. So please stop me if you have questions, tell me if I'm talking too quickly. We have a presentation behind me that I will be going through and a couple of handouts that we'll review. So thank you for coming, much appreciated, and I hope this is useful information to you. So again, today our topic is arthritis management. Again, I hope this discussion can be interactive in nature. Arthritis is so common, but it's also commonly misunderstood because there's many, many types of arthritis. So hopefully we'll clarify some things and we can leave today with some ideas of useful strategies to help mitigate the pain and maintain function. So arthritis actually is the leading cause of disability among older adults. We're going to talk about the types, symptoms, and care for arthritis, along with tips for managing the pain and discomfort. We will also do a demonstration, and I use the we because it's not just me that's going to do the demonstration. We will go through some exercises, stretches and exercises that are simple that can be completed at home. So let's get into the big thing. What is arthritis? Arthritis is a very, very general term. It covers a large classification of joint disorders. The word itself, arthro, means joint. Itis means inflammation. So in its purest sense, it's an inflammation of a joint, which can be caused through varied means. It may damage joints, it may damage bones, muscles, cartilage, and any other connective tissue that surrounds the joint. It could lead to deficits in your physical movement, and there are two main classifications of arthritis. Can you see okay?
Well, just the last one I can't see because the camera's right in front.
Oh, I'm sorry.
That's all right. It's fine.
Osteoarthritis and rheumatoid arthritis are the two major classifications, known as OA for osteoarthritis or RA commonly for rheumatoid arthritis. And they're actually pretty different animals. We'll look at the joint very, very briefly. He's kind of broken out into two different parts. The right side, if you're here, is the osteoarthritis. Cartilage in your joint. So you have cartilage, you have discs, it depends what joint it is. You have things that buffer and provide spring and protection between the bony surfaces of the joint. Osteoarthritis, there's a eroding meniscus, there's eroding buffering, so as those joints are used, wear and tear of those joints over time, you get more bone on bone. You lose that nice, soft buffer disc protection that we're born with in those joints. Rheumatoid arthritis is more of an inflammatory process. So you've got erosion of the bone, you've got swelling and inflammation around the joint, which tends to be the culprit of breaking down the tissues around the joint. And you have something called bony ankylosis sometimes, where you get bony spurs sticking out within the joint, which just alone sounds painful to me. So we're going to compare a little bit more clearly a normal joint, an OA joint, and an RA joint. And I'm sorry to put my back to you. So in our normal joint, you can see the two sort of cream-colored sections are the bones where they interact. Muscle, bursa is kind of a fluid sac around some joints. Cartilage, fluid, the membrane that keeps the fluid in, that is all held within a joint capsule. So the joints aren't just bones together. They have usually a nice fluid capsule around them that keep them integrated, that keeps fluid in there, Again, the more moist, the more fluid, the more lubricated and easily movable your joint is. When we have OA, we get that cartilage, that sort of soft tissue that wraps around the end of the joint. The cartilage wears away through use and time and just being an active person. And as that cartilage wears away, you lose that protective function of the cartilage and you get the bone on the bone. So you can see with the OA, what we're looking at are the two bony segments right up against one another. With the rheumatoid arthritis, it's an inflammatory response. So it is a systemic response in your body that inflames the fluid, inflames the joint. So it's hot, it's red. It's not so much a breaking down of the joint as it is a process that's causing deterioration of the joint. OA is more common. OA is more typical. I've used my body all my life and now I have OA in my joint. RA is a diagnosed process that fewer people have. So let's look at some statistics, always fun. So 33.6% of the people 65 years or older have some kind of OA, osteoarthritis. 30% increase in the risk of falls for individuals with OA in their hips and the knees. OA often happens in the weight-bearing joints. And when we talk about that, we talk very much about hips and knees. We walk, we climb, we do things all our lives, and that cartilage breaks down in those joints that take on a lot of our weight through our lives. So having the pain and the dysfunction in those joints is a risk factor for falls. When we're looking into the future, as we know, our population in this country is aging pretty dramatically. The prevalence of doctor-diagnosed arthritis is expected to increase in the coming decades. By 2040, which when you blink, that doesn't seem all that far away, an estimated 78.4 million adults will have doctor-diagnosed arthritis. And we say doctor-diagnosed arthritis because many people go through their lives having some stiff knees in the morning, a little achiness. That's osteoarthritis. It's never been formally diagnosed. There's many more people than that carry around OA without it being formally diagnosed. And 2/3 of those with arthritis will be women. Lucky us. So this is just a graph which kind of puts a visual around where we're heading with OA from mid-2000s up to 2040. You can see the projection of the number of people with OA in this country. So let's talk more about that. As I said, it is a progressive loss of joint cartilage, wear and tear. That's sort of the easiest way to just sort of in your head think about what osteoarthritis is. You have these joints with lovely cartilage that provides fluid, provides cushioning, provides prevention of those bones banging one on another. Over time, wear and tear, that breaks away, breaks down, till you get that bony, bone on bone. Typically limited to one or more joints, not typical a systemic condition, which is what RA is. RA affects you head to toe. It has other sequelae associated with it. OA is joint. It's wear and tear joint. And again, as I mentioned, it's a bone-on-bone feeling, which fortunately I'm not sure what that feels like, but it doesn't sound like it feels very nice. So what are the symptoms of osteoarthritis? Obviously joint pain, caused by weakening of the muscles that surround the joint, often due to inactivity. This is where we get into that sort of vicious cycle of, my knees hurt when I walk too much, so I'm not going to walk very much. And you get up in the morning, your knees are stiff and they hurt, so you don't walk very much and you do less, and you kind of fall down into this cycle. And it used to be strongly thought that you shouldn't exercise with arthritis. And we'll move on to talk about why that is no longer the case. Joint pain is often, or usually, less in the morning and worse in the evening. There's often an element of stiffness in the morning, not necessarily pain. And as you get going during the day, that stiffness kind of loosens up a bit, but by the end of the day, those joints wearing on each other all day long, a lot of evening, nighttime pain. Again, sort of talking and not reading. The morning stiffness usually lasts no more than 30 minutes. It's just those joints have been stuck in one position overnight, and they take a little while to get what lubrication may be in there going, okay? So symptoms, and this time rather than looking at a hip or a knee or a joint, we're looking at the back, because OA happens quite significantly along the vertebrae too, and we'll talk about that. So joint stiffness after periods of rest goes away quickly when activity resumes. Again, stiffness in the morning because you haven't moved a little bit, that fades away. Joint enlargement due to bony spurs sometimes happens. So when bone rubs on bone, for some reason the body creates calcification. So we create this little added area of bone, which is called a bone spur. And then you have more bone driving against bone. So you get this calcification or a bone spur, which those things, stiffness, pain, bone spurs, creates for us pain, sometimes lack of coordination, sometimes difficulty walking, challenges getting up from a low chair, all of those sorts of things. And I see a lot of nodding heads, because in our hips and our knees, when they're sore like that, those are the things that start us feeling it, right? Getting up from a chair, getting up from a toilet, getting up from a bed. We talk about the spine really quickly. So a normal spine, again, this is it's a nice place to see really what discs do. We talk about bulging discs and slip discs and those sorts of things a lot. So your vertebrae are bones stacked up in a very, very distinctive pattern in your spine. They're not like bricks that sit very uniformly atop one another because they're not a uniform shape. They're kind of a fat on one side, skinny on another side. So when they stack up, they form curves because our spine is not straight, it's curved. So you can see in the picture where it's got this gentle curve here and those discs sit in between. What happens with the osteoarthritis, along with postural changes with age, those discs can be pushed out from between the vertebrae. I'm going to come over here. You might not hear me real well. But if you have this nice curve in your low back, and through life it starts like that, so those bones that are sitting on these angles that maintain those little curves, suddenly sit on different angles. Then those discs can slide out. They can slip out because we're taking those bones and changing how they're stacking on one another. When those cushions slip out, then in the spine we end up with bone on bone. If we have bone on bone in the spine, we also potentially can create those spurs, which may put pressure on some of the nerve roots or the spinal cord, which then will have other sequelae, which it could be radiating pain down the legs if we're squeezing some of those nerves. So again, we talk about hips and knees a lot with osteoarthritis, but it's often highly painful when we have it in our spine.
What is
sequela? Results of. So you have this change in posture, you have bone on bone, you create those spurs may then create the radiating pain if it's squeezing on your nerves. Good question, I'm sorry. So symptoms of OA, very generally, OA occurs most commonly in the weight-bearing joints, as we've said, but it does occur in other joints, in your hands. And if you look at your hands and you see little bony spurs or just kind of little lumps on some of your joints in your fingers, that's a sign of osteoarthritis in your fingers. Your cervical spine, your lumbar spine, knees, ankles, hips, feet. So most joints are vulnerable to OA of some sort. So we'll talk a little bit about RA. Again, it's a different animal, but often people hear arthritis and all kind of gets lumped into one bucket. The treatments for both is quite different, so it's important to know if you have RA as opposed to if you have a more typical OA. So RA is a systemic disease which affects the joints rather than a joint disease, but it also, because it's systemic, can affect really important organs. It's an inflammatory disease, so it's inflammatory of the connective tissues. You have connective tissues all over your body, so if they're inflamed, again, it's not just joints, it can be lots of other really important parts of your body. It is characterized by flare-ups and remissions. If you have RA, you might wake up one day with a hand that is hot, red, and swollen. There may not be any real immediate cause that you can figure out from that. It's an RA flare-up. You have an inflamed hand. It presents as an overall joint inflammation. So again. So symptoms of RA, it's an immune system that attacks the synovium, the synovial, synovium is fluid around joints, but it also can be fluid in other parts of your body. So it lines the membranes around your joints, and that can become very red, it can become very inflamed. And it thickens the synovium, which can eventually invade and destroy the cartilage and bone around your joints. So with arthritis in the hands, particularly if you have RA, you're going to see some very common looking deformities. And we see one hand right there where the fingers, we call it ulnar drift, and they kind of drift out towards the pinky side of your hand. It's because these joints are unstable now because of this inflammatory process that has broken down the connective tissue. So every time I lift something up or every time I turn a doorknob and I'm putting pressure on these joints towards my ulnar side, over time those fingers stay over there. They drift over there because of how we consistently put pressure on those joints that are inflamed. So we see some very specific patterns of deformity that come with RA as opposed to the OA. With RA, conversely to an OA, the morning stiffness can last for hours. Again, it's not stiffness necessarily caused by that period of rest, it's stiffness caused by the process of the inflammation. You'll have joint pain, again, that fluctuates with whether you're in a flare-up or a remission, and you will have joint deformities. Again, very specific patterns of joint deformities because the tendons and the ligaments and the things, the connective tissue that hold your joints in alignment gets damaged, so you don't have the stability in your joint. And symmetrically, RA often affects joints. So you have RA in these joints of your right hand, you're likely going to have RA in these joints in your left hand. Again, it is a whole body systemic disease as opposed to OA, which you often have more in your dominant side because it gets more wear and tear. So it's another little difference between them. So this is an x-ray of a normal hand as opposed to a hand with RA. Normal hand, you see the beautiful alignment of the finger bones, the metacarpals, everything's nicely aligned, how you'd expect to see a hand. And you can see almost like a Z shape going on with the arthritic hand. Again, the way we use our joints, just daily function, daily use of our hands, if we have joints that have no connective tissue to speak of, that daily use will create deformity. And we see that here. And it gets to the point that bone gets displaced and we really lose structural integrity of the joints. Symptoms of RA, often RA, we think about it more in the hands, and I think we've probably all seen people with arthritic hands and it's very sort of identifiable, but hands, knees, wrists, hips, elbows, feet, and shoulder. RA often affects smaller joints first, whereas OA we look at the bigger joints first. Again, RA is often symmetrical, often starts in a couple of joints, and again, wrists, hands, smaller joints as opposed to the bigger weight-bearing joints. To make a diagnosis, of osteoarthritis, most doctors use a combination of methods and tests. Medical history, and I say this to people all the time, when you go see a doctor, nothing is too small to tell them, nothing is too big to tell them. So much of diagnosis happens from knowing you, knowing the things that hurt, when it hurts, what you're doing that causes discomfort. It is really important just to lay it all out there. So medical history is one of the most critical parts of diagnosis of anything. Talk about your pain, talk about your stiffness, what your joint function is. Hopefully they'll measure joint function as well, and how these things have evolved or changed over time. A physical examination will also occur, which will look at your joints, your skin, your reflexes, and your muscle strength. X-rays will probably happen, but they're limited in their capacity to really see any soft tissue changes and how much joint damage beyond the bony changes. They're not going to see the connective tissue loss or the changes in the synovium, for example. X-rays only see bone. So X-rays usually don't show OA damage until there's been a real significant loss of cartilage. And then you can really see where those bones are hitting upon one another. So the main thing...
Would an MRI show more?
An MRI might show more, yes. Yeah. Costs a lot more, may not be necessary, but yes, it would show more. So the main thing for all of us, right? We don't want to be in pain, and we want to be as functional and vital and productive as we can. So most treatment plans, when you have OA, or RA, include a combination of the following elements: medications, lifestyle changes, stretches and exercise, joint protection, and often OT or PT to kind of push you in the right direction and guide you with those things. In some severe cases, when these therapies aren't effectively managing the pain, surgery may be considered. Knees replaced, hips replaced. More often than not, the reasons for those surgeries are progressive and progressed OA in those joints. So what medications are used to treat arthritis? Lots of different things. And it's really going to depend on every specific case. And again, it just backs up why you need to be very clear with your doctor about your symptoms and those sorts of things. So it's going to depend on your level of pain, what else is going on in your body. So when we talk about comorbidities, those are other diagnoses you may be carrying. Do you have cardiac issues? Do you have blood pressure issues? Do you have breathing issues? All of those things will help define medication management. A risk and possible side effects from the medications. Obviously, we need to look at that, what you might already be on, how it's going to impact or have an adverse relationship with any new medication. So always bring all your meds to your doctors too. So NSAIDs are one of the most common first-line pain management, non-steroidal, anti-inflammatory drugs to take that inflammation, calm it down, take that process and hopefully eliminate it in your joints. Steroids, straight-up pain relievers, hopefully analgesics before we get into the narcotics, and then immunosuppressive drugs, and that would be for the RA piece, because again, it is a full body, it is a systemic disease of inflammation. You wouldn't go that route necessarily with OA, but with RA, immunosuppressants often work.
What is analgesic?
It's just a word for pain medication, Tylenol, Aleve, Advil,
Okay.
yeah. So lifestyle changes was the next one in the list of management, right? It was medication. None of us want to be chock full of taking 20 different meds every morning and every evening. So are there things that we can do that are non-pharmacological? So lifestyle changes are really important to maximize treatment for arthritis. One of the big ones, especially for OA, is weight management. And I'm looking at this group of people, and it doesn't look like anyone in this room has an issue with this. But just think of the greater impact on your hips and knees if you're carrying around 15, 20 extra pounds in your body. Weight management is hugely important. There's oftentimes you go to your orthopedic surgeon and you want an elective knee surgery because you've got terribly painful knees, and they will, in the nicest possible way, say, come back in 6 months when you lost 20 pounds. Your outcome is going to be so much better. And in the course of losing those 20 pounds, the pain in your knee may resolve to a certain extent that you won't need it. It's really huge impact. And when we talk about weight, often you think about your joints, but added weight puts more burden on your heart and your lungs and your whole body. So really is a lifestyle management tool for health and fitness generally. Think about weight mitigation. Sleep. Seems silly, but gosh, would I love 8 to 10 hours of sleep a night for every reason. Getting good restorative sleep every day can help you recover from RA flare-ups and even help prevent future flare-ups from coming. I have no idea why that's the case, but believe me, I'm a huge proponent of getting a good night's sleep. Kind of like the weight management thing, there's lots and lots of benefit. There's tons of benefit from getting good night's sleep as well. Eat healthy fits in with the weight loss. A diet full of fruits, vegetables, and foods rich in omega-3 fatty acids is very helpful for your joints. Stress kicks up inflammation in your body. So stress appears to directly impact flare-ups and your ability to recover from flare-ups. Again, I'm not hugely technical. I don't know physiologically why stress creates an inflammatory response or makes it worse, but there's plenty of evidence out there that says it does. So again, especially for the RA piece, which is a much more inflammatory driven process, sleep and stress is really things to think about. So therapy, overall goals of therapy, maximizing mobility. We want everybody to be able to get from point A to point B safely without pain, wherever point A and point B happen to be, whether it's 10 feet or 100 feet, right? Maintain your joint mobility. As we've already said, getting in and out of a chair, stepping into the shower, putting your shoes on. We need joint mobility to maintain function, right? We need to reach, we need to bend, we need to twist, and hopefully we need to do all of those things without stiffness and pain. Prevent joint deformity. Once those joints start developing those very patterned deformity, it tends to get a life of its own. So we need to learn ahead of time how to change how we use our bodies so we're not always creating stresses in the same way on the same joints so that we can help minimize the development of deformity. Maintain or improve strength. The more muscle strength you have, the more support you have of those joints. Maintain or improve ability to perform everyday tasks. So sometimes these tasks are difficult because we've got stiff hips and knees. There may be ways of compensating for that so that we maintain our ability to do things independently. Obviously, goal of therapy, goal of all of us is decrease pain. We want to develop a plan for balancing activity and rest. Sort of a plan is really important. I'm going to pause here for a second. When you're in pain and when you're stiff and when normal activities of daily living, whether it's getting dressed or walking to the bathroom or meeting someone in the dining room, when those tasks are painful and hard, we get very fatigued. Fatigue comes along with this whole package deal. So we need to kind of create a way of balancing activity with rest to still maintain function. And the same can be said for a lot of disease processes. It's important to kind of have a little bit of a self-analysis and know how much is a good amount, how much is too much, can I balance this with that and have a rest here? If I've got tomorrow, I know I need to go out down to VCU for an appointment that's going to take me all day. I'm not going to have my hairdresser appointment on that day too. So just in managing what the demands of your body are, not stop doing things, but do them in a very thoughtful way. And develop problem-solving skills to modify your daily activities for joint protection. So it may be, I know I always sit in that couch, but I've noticed after the last 6 months, it's really hard for me to get up off that couch. It's low, it's soft, I don't have a good way of getting up, so I'm going to start sitting in that chair, which is taller, firmer, still comfortable. I can still see the TV. So it's a matter of sort of thinking about those things as well, so we don't just fall into, I've always done it this way, I've always sat there, and we just sort of continue our old bad habits, because that's kind of what we all do. So exercise. Exercise is a therapeutic intervention. It's one of the best treatments for osteoarthritis. Exercise of any kind will improve mood, it'll improve outlook, it'll decrease pain, increase flexibility, and help you maintain a healthy weight. So it's checking off lots of those boxes. And it will help decrease that cycle I sort of mentioned of pain, weakness, joint degeneration, more pain, more weakness, more joint degeneration. I'm struggling with that word. So we can see it up there. You've got pain and swelling in your joint, which creates weakness. You get degeneration, creates more pain and swelling. You do less, you get weaker. So exercise is going to cut that off. It's going to keep us as healthy and active as we can. Exercises can be variable, right? And should be variable. We all get bored with doing the same thing all the time. So low impact aerobics are great. Getting in the pool to do aerobics is great. Building endurance, okay? Range of motion to maintain the flexibility and the joints moving as far as they can. The last thing we want to do is have permanent contractures. And what that means is, if my elbow goes from 0 degrees to 160 degrees, if I have arthritis in there, I may get to a place where I'm stuck at 20 degrees and can only go to 95 degrees. A contracture is a permanent limitation in joint range of motion. Typically doesn't happen in the elbow, but that was the easiest joint for me to show you. And strength training is really important too. So we're looking at endurance, we're looking at flexibility, but we're also looking at strength. We want good muscle tone, enhancing the muscles around the joint to give the joint more structure and stability. Here we go. We've got people in the pool. Aquatic exercises are phenomenal. You have so much less stress on your joints when you're in the water. You've got that buoyancy, so you can do a lot more with a lot less stress. Water lessens gravity forces on the joints, lessens the stress on the muscles, it lessens the stress on the joints and the bones. Heated water is even better because you get that therapeutic warmth around the joint, which makes them have blood circulation, keeps them lubricated, makes your joints easier to move, and you get improved range of motion. So what you may be able to do on dry land, you might be able to do exponentially more if you're in the water. The amount of and form of exercise will depend on a lot of things. Which joints are involved, the stability of those joints, whether or not the joint is currently swollen, or if you've already had a joint replacement. And what I'm going to add to it, if we're talking RA as opposed to OA, if you wake up one of those mornings and it's a cycle up and you're flared up and you've got a very red, hot, angry joint, that's your body telling you to rest. So we need to put that apart. If we're having a rheumatoid arthritis flare up, we take a rest. We don't do anything up to that joint because you could damage the connective tissues. But otherwise, think about, I'm going to create my exercise surrounded about which joints do I want to really focus on, how stable they are, what's already happened to that joint, and think it through that way. So that's where therapy often comes in, specialized in exercise as a modality for strength, mobility, balance. They can help define a program that fits with you. And we're really blessed here at Cedarfield because we can do that in our therapy clinic, and then we can take you to the fitness center or to the group exercise class and kind of help transition you to a much more self-motivating, self-directed exercise program. I know there's some people in here who are nodding who've been through that process, so it's kind of a really nice, smooth transition to help you continue doing what you've learned in the therapy gym. In your handout, there is one that says Arthritis Management. These are simple, daily, stretching kind of exercises. I think most of these are up there in your handout. The goal of these, again, these are stretches primarily. The goals of these are to maintain the joint integrity and maintain your range of motion as much as and for as long as you can. Not all of these will be appropriate for everybody sitting in here. If someone's had a cervical fusion, they're not going to do a lot of head turns. So you need to know your own medical history. But this handout just has some very simple daily stretches that would be good for all of us to do, whether we have arthritis or not. It's really good for the joints to be given a chance to go through their full range, open themselves up, have a chance to move every day. So very simply, we've got head turns, we've got arm reaches, which affect the shoulder, we've got shoulder circles, which not only are really nice for the shoulders, but posturally. Life happens in front of us. We all tend to get a little rounded, and our head comes forward and our shoulders come forward. Everybody's sitting up for me now, but pulling those shoulders back, opening up the chest, having a more upright posture is really important. Our bodies were designed in a way to work, and we tend to not work them in the way they were designed, just through life and fatigue and pain. So the more we can get back to the way our posture is designed to be, the better our bodies function. We've got a stretch this way, which, based on which arm is where, puts a different stretch on each shoulder. Let me see what else we have. Elbow bends, turning. Sometimes we forget about all the different functions that different parts of our body do. So the supination, pronation is important. We don't think about it very much. Wrists up and down, finger curl. I do want to tell you one very specific thing about the fingers. We often think about making a fist like this. What tends to happen with osteoarthritis is it's these little joints called the pips and the dips, the proximal interphalangeal joints and the distal interphalangeal joints. They're the ones with OA tend to get tight. So when you're thinking about making your fists, make a hook first and then roll it into a fist. That way these little joints maximize their range as well, okay? So we talked about the wrists, we've got knee lifts. Knee lifts are actually working a lot of the hip, not just the knees, because when we lift, we're getting hip flexion, which we don't get a lot of unless we're stepping into a tub, picking up those hips and doing that. We don't do that a whole lot, so that's a good one to do to keep hip mobility. We've got a leg bend and lift, and we've got ankle circles. So again, not all of these are appropriate, but it's a really nice sort of head to toe, quick and easy way of stretching your joints. So joint protection. As a therapist, we talk about joint protection all the time. And it's really a series of techniques, things that we do to relieve stress on joints, as simple as that. Joints have been weakened by arthritis at the risk of being damaged by just repetitive use and stress and strain. So PTs and OTs can assess how you use your body. What are the patterns of movement that you particularly have that accentuate the stress you put on your joints? How can we protect those joints? Very, very simple little picture here. I wish I'd brought a different kind of cup. So if we have arthritis in these joints here, specifically RA, for example, and these joints are inflamed, and I always pick up my coffee cup with my right hand, the weight of this cup is constantly pulling these joints this way. Again, if I turn my doorknob, I've turned the stove knob, any of those things, I'm constantly putting pressure on these joints to make my fingers go this way. And that's why you see that ziggy-zaggy pattern in these joints. So what can we do to do that differently? We can use a cup that doesn't have a handle that pulls your fingers down. We can use two hands, so we're distributing the stress on those joints. So that's just a very simple example of joint protection, is analyzing how we are consistently using our joints, how that might be creating deformity, pressure, damage. What can we do to change that? Opening the door, if I'm right-handed and I'm constantly doing it with my right hand, I need to tell myself once in a while, well, open my door with my left hand, because then I'm taking that stress and putting it the other way, and I'm resting my right hand. This other one is carry things. Forearms, what I'm using now are big joints. I'm using my elbows, I'm using my biceps. I'm not carrying something again with my fingers where my joints are carrying the weight in that same deformity pattern, if that makes sense. So there are lots of ways of analyzing how you use your body and looking at, let's use these bigger joints. Let's try and change how you're holding it. Let's use this hand. Rather than mixing like this, we're going to mix like this. So taking a look at the things that could be causing your joint pain and weakness. Are there different ways of doing it? And oftentimes that does not mean having to use a reacher or this and tools, and a lot of people don't like all this equipment. There can be lots of very, very simple things that can be done in just the way you're doing that task. So this is another example. Improper use of effective joints may lead to impaired function and increased deformity. Joint protection techniques are ways of doing activities so the risk of deformity is decreased. So you can see the difference in the way the person is holding their hands. Incorrect, the pressure on the fingers and the joints, just the way they're doing it, as opposed to the way they're doing it in the second set of slides. Essentially, bigger joints take more stress than little joints. So think about especially how you're using your fingers, what kind of stress and pressure is being put on your fingers. So joint protection is a huge part of the therapy intervention, exercise prescription and training, but also pain control. Pain is a really limiting factor when you have arthritis, right? Nobody wants to get up and move and do things if it really hurts. So many suffering with arthritis find their activity just over time declines. You do less, we get that pain cycle that again I've talked to you a little bit about. You have pain, so you guard your body, you use your body differently. How many people have we seen sort of walking that are really stiff with their rollators because it hurts and you hold your body kind of rigidly, you want to protect yourself, which then often creates a muscle spasm or inflammation in your muscles because they're overworking and they don't know how to relax anymore. That restricts your mobility, which creates muscle weakness because you're not doing as much. Loss of normal function, you get more pain. Well, you get mad about it first, and then you get more pain. So as you can see, unless we kind of break somewhere in that cycle, it can be a really downward spiral towards more pain and dysfunction.
May I ask a question?
Yeah, of course, please.
Is arthritis hereditary?
Some types of arthritis are. Osteoarthritis is not.
What about RA?
RA is. There's a genetic component to RA, yes. I'm sorry, that didn't look like the answer you wanted. So how does therapy intervene in pain control? Lots of different ways. We are taught and trained how to do something called joint and tissue mobilizations, which are really manual techniques, almost sort of when you think of what a chiropractor might do, to help align joints, to help stretch and mobilize tissues, to try and help return the integrity of a joint. So we help create proper alignment of the joints and tissues, which then may, we hope, reduce pressure on some sensitive areas. We increase flexibility that way. Anytime we can get those tissues moving, we have better blood flow, which then relaxes the muscles. So when we get into that muscle spasm, there's a lot of manual techniques that we dig and prod and move tissues around to help release those tense muscles. We use hot and cold packs depending on what's indicated. Uses that fancy word up there, vasodilation. What that means is the opening up of your blood vessels. So heat opens up your blood vessels, we get more circulation, more blood flow, more lubrication, more nutrients coming into the joints. Conversely, cold vasoconstricts, so it tightens things up. And there are good times for that. Ice helps reduce inflammation because we don't want all those inflammatory processes going on, so ice slows that down. There's a lifelong debate. Should I use heat or should I use ice? Should I use heat or should I use ice? The go-to is if you're within 24 to 48 hours of an injury, ice is typically recommended because, again, we want to stop the inflammation. We don't want that ankle to get all swollen up and sore. If it's more chronic than that, more people prefer heat. And heat just is easier to tolerate for most people. Heat, again, increases that circulation, relaxes the tissues, allows better range of motion and movement. We use something called TENS, which is transcutaneous electric nerve stimulation. It really doesn't matter what it is. It's just a modality we use that puts low levels of electric stim in muscles, and it works well for pain management. Stimulates nerves, stimulates movement. We use ultrasound. We use lots of different things. There's lots of modalities that we can use for pain management. Oftentimes we find, we'll have someone on our caseload who'll call one morning and say, I'm not going to come down to therapy today. I really, really hurt. It's just a bad day. Promise you, that's the best day to come down to therapy. We will modify, modulate, figure out our plan of care to manage that pain. And it may be heat, massage, some stretching, and you might feel a whole lot better. So don't be afraid of therapy when you're in pain, because we often can really relieve a lot of that pain. Splints and braces, we never want to jump immediately to bracing or splinting something, because then there's a couple of downsides to that. You're losing the function of that joint to a certain extent. You're losing those muscles that work the joint because we're supporting and stabilizing the joint. But there are very definite times and places where splints and braces are really indicated, especially with RA, when we're looking at the hands where we may have really inflamed, sore joints, that your body is crying out for rest. That's what the inflammation is telling you. And we can put joints on to support wrists, supports fingers, that allow you that rest. Probably wouldn't be something you wear 24/7 every day, but it's a real good go-to when you're having one of those flare-ups. Other joints and splints can be used to support a really weak or damaged joint. You think about a knee that's really severely damaged from osteoarthritis, and you no longer have really good connective tissue, and as you walk every once in a while you get that, my knee's going to give out, so you don't walk and it hurts, and then we've got that cycle. Sometimes a knee brace will be just the thing to give you the support you need to maintain your level of activity. So therapists will help identify the type of splint, when it should be used, what the most beneficial for your current situation. Again, splints are often used more with the rheumatoid rather than the osteoarthritis. And then talk briefly about adaptive equipment. A lot of people are sort of, I don't want that, and I don't want to go to the dining room, I have to have a special cup, and whatever. And I totally understand and accept that. But again, there are times where a couple of pieces of equipment can save you from not being able to do something independently to being able to do something independently. So it's part of the therapist's job to work with you and define what is the right time and place and what type of equipment you might need. It might minimize your pain. It might help you compensate for the ability to complete a task that you could or used to be able to do previously. So assistive devices can make it easier to go about your daily things. So this first one is just a little tool that pulls the tab up of a soda can. If your fingers are very inflamed or stiff from arthritis, that's hard to do. The second one is a jar opener or doorknob opener. If it's hard for your fingers to manage a round doorknob, You can put something on with a lever, which again allows you to use big joints as opposed to small joints. And finally, we've got just a selection of kitchen type things. Handles, bigger handles are better than smaller handles, easier to hold, take less stress. Things with levers are better than things that don't have levers because the force is less when you've got a lever arm. So it's just, there are thousands, and I do not exaggerate, of tools and equipment and things out there to help you be functional. And literally, we have catalogs this fat. So, if there's something you used to be able to do and it's frustrating you because it's hard and you can't do it anymore, just drop by and say, hey, have you ever heard of something that might help me do this? There may be just something like that we can show you, get for you, and it may just take the stress and frustration of a task away for you. So, in conclusion, it has been proven that people who take an active role in their treatment of their arthritis tend to have better quality of life, reduce their sense of suffering, and feel more empowered. And we all want that, right? Allow your therapy team, if you're wanting to come, to work with you to develop a plan or a program to maintain or regain your quality of life and independence. I do want to briefly tell you you've got another handout. And my apologies, it is so tiny and it's written so small, so if any of you want me to try and enlarge it, for those of you, because it's like my 55-year-old eyes can barely see it. But it's just talking more generally about arthritis and exercise. I think I mentioned earlier, there has been historically this sort of, I have arthritis, I shouldn't exercise philosophy. This is talking really about fundamental guidelines and why that is no longer held true. It is really good and will benefit you, again, keeping your joints flexible, easing stiffness, providing muscle strength that will support your joints. Obviously, as we know, good exercise and weight bearing will improve your bone density. It'll maintain your ability to do daily activities. So this really kind of has been touched upon through the whole presentation, why it's important to exercise and the benefits of exercise. And if any of you have magnifying glasses, you could read that. And again, I apologize for the size. Does anybody have any questions or comments?
Is there anyone here that gives massages?
In therapy, we do a certain type of massage, but it's not like a head-to-toe massage. I know there are 2 or 3 people who do come here and will provide massages. I don't have their names in front of me, but I can get them for you. But yes, there are a couple of people, qualified masseuses, who come and will do visits and bring their tables and set them up in your living room and give you a massage. Anybody else?
It's not a question, it's kind of a response. The Sit and Get Fit exercise classes 3 days a week, 10 o'clock in the morning, are just doing all these exercises you just showed us. All of them.
It's perfect. And I can't tell you guys enough how fortunate you guys are to live in a place that not only feeds your physical fitness through something like that, which is accessible from your own living room, to all the offerings in the fitness center, having a gym here, having a pool here. So this community feeds your physical needs, but the art center and the music offerings and all of those things to make us really holistic people. So I'm glad you mentioned that, Perky, because it's wonderful. You have Tai Chi, you have yoga, you have Sit and Get Fit, you have things that should fit every single person's individualized needs.
After you exercise, like lift weights or something, is it good to get in a hot tub or is that nothing?
Oh, feels great, do it, yeah. What a true exercise physiologist person would probably tell you, if you've exercised hard, The best thing to do is cold immediately after, because that kind of slows down again the lactic acid buildup, the things that might create that next day muscle soreness. But yes, relax those tissues. A hot tub is great. Getting in the pool after you exercise. I'm a believer if it feels good, it's the right thing for you. Yeah, and I love heat after exercise. Or did you say, or a glass of wine? Is that what she said? Anything else? On the back table, I believe there are surveys. I think there's just like 5 simple questions that you put a check mark to. If you guys could fill those out on your way out and leave them there, I'd really appreciate it. One of the most important parts of the survey is on the bottom. There's a place for suggestions for topics. Next month, we're doing dizziness. We've had a couple of people ask us about vertigo and about dizziness and what causes that and what we can do about it. So that's next month. But October, yes, I'm not skipping ahead months, although saying October sounds crazy. So September is dizziness. October is up in the air. So if you guys have topics you want to hear about, please jot it down on your survey and leave it behind for me so I have some thoughts about what you guys need. So once again, thank you. Thank you for coming and listening. Appreciate it.
Penny, I'd like to talk to you about something.
But you know what?
Well, this will take less than a few minutes. We had somebody from physical therapy come to our neighbor's house.